There we go. Hello, very pleased to have Dr. Stephanie Gallard join us. Hopefully we're going to have a straight session this time, as opposed to last time's technical issues, talking about dermatology below the waistline. And I think it's probably fair to say that we are going to focus mainly on women's area, or so I'm not sure, will we be talking about anything to do with men, or we're open to questions on men at the end?
We are open to questions. I think it's an area of our bodies which is usually more of a problem for women, certainly more of a problem that I see in general practice. I would argue the women outnumber the men I see with genital skin problems by about 10 to 1. So wow. We will probably be focusing more on women, although we are all inclusive and happy to discuss men, but women are the main issue that I see as a general practitioner.
Okay, so Stephanie, we've got a couple of questions that have been posted in prior, which we will cover at the end. Please feel free to post your questions as normal as we go along. And so I think a good thing to do would be to kick off for Stephanie, if you'd like to tell us a little bit about yourself. But what I would like to say, and I think it's really important, is that when we've done skin before, we've had dermatologists. But Stephanie isn't a dermatologist, but she is one of the most important people that you would see at a GP surgery, because she's called, well, I think that you're called gypsies, aren't you? Somebody who has a special interest in dermatology. And what we would always stress is that if you have a skin condition, you've got a concern about your skin, ask your surgery, do you have a doctor that specialises in skin? Because if they do, please go and speak to those people, because as you'll find out today, Stephanie is so informed about skin, it's amazing. So Stephanie, please tell us a little bit about what you do and what what your day job is.
What I do. Well, on a Tuesday, I am what you would call a normal GP. And I sit in my surgery and I see all manner of problems from top to bottom. I am a general practitioner. Obviously, my partners know of my interest in dermatology, and I will sometimes see referrals from the other doctors and nurses that I work with, where they are looking at things and thinking, I don't know what that is. And sometimes these days, with the increasing use of teleconsults, then if one of my partners takes a phone call from somebody saying that their child is having an issue with their eczema, or their eczema has flared, they won't bother seeing them. They'll just say, well, I'll book you a face-to-face appointment with Dr. Gallard. So that's one day of my week. And then all day on a Thursday, I'm what they call a GP with a special interest. And there's all sorts of us now across the country. To be fair, GP with a special interest is the older qualification. They've updated it now a little bit. You'll see we're not particularly called GPSIs anymore. There's another title for us, and it's known as a GIPper, and that's a GPWER. And that means GP with an extended role, but that's very much a newer terminology. But the important thing is both GPSIs and GPWERs, gypsies and jippers, we've all got some sort of extra qualification in an area that particularly interests us, and obviously mine is skin. And we're normally, according to Royal College guidelines, we're normally accredited by the consultants of the secondary care trust near where we work. So obviously I work in Liverpool, and I've been accredited by our big hospital, by the Royal, to be a GPSI for the last 15 years. And to be a GPSI, you normally need some sort of extended qualification. For dermatology, it is invariably the Cardiff diploma, which is a 1-year all-encompassing diploma in dermatology that you do on top of your day job. I think it costs about £15,000 now. It's quite expensive. Or you can be a GPSI in diabetes, and the GPSI course in diabetes is from Warwick University. But that's another very, very well-known one. And we work in conjunction usually with secondary care. So the all-day Thursday, to drag it back to your original question, I see patients not as a GP, but as a clinician with a special interest in dermatology who works for the hospital. And when I'm in my GPSI clinic, I see people who've been referred to me by my fellow GPs from across the city. And I can either discharge them from my clinic with information on self-management, or sometimes I refer people up into the hospital for different treatments.
And also, one of the other thing that you do, I know you do, is that you actually go and teach, you tutor as well.
Yes.
As well.
I do an awful lot of lecturing for medical students, for pharmacy students, for nurses. I think me being here talking to you is a first, because I'm talking to people as opposed to other healthcare clinicians. I've just signed up to be an external examiner for the University of South Wales, which I'm quite looking forward to. I think that's going to be quite interesting. And I do a few other bits and bobs. I lead on what they call teledermatology. I'm the primary care lead for the teledermatology in Cheshire and Merseyside. And that means we are, in our efforts to cope with some of the delays caused by the pandemic, we're introducing teledermatology, which is where you will take a mole and you will go to your GP, and your GP will look at the mole and think, ooh, and I'm responsible for putting equipment and software into your GP surgery and onto your GP's computer that will mean a photograph can be sent across to the local hospital for them to look at and give an opinion on and send back to you within a few days, which is something that we've not had widespread across Cheshire and Merseyside before. So it's interesting.
Yeah, and funny enough, I mean, things like that are really, we will get on to talk about what we're meant to be talking about in a minute, but it's interesting. We've spoken to a lot of digital companies that are really pushing the teledermatology or the photographic stuff, because the process, as I understand it, has been such a slow process, and now it seems it's really whizzing it up digitally with getting prognosis of skin cancers and things like that. Yeah,
I think undoubtedly the pandemic has produced massive shortcuts. There's never been such a drive, partly because during the initial days of the pandemic, it was nearly impossible to see anybody face to face, because that was government guidance. Government guidance was that GPs should not be seen face to face other than in very extreme circumstances. I myself have never stopped seeing patients face to face right the way through in general practice, but also because of those difficulties, as we've touched on, the waiting lists have just got bigger and bigger and bigger, and it's a very good way of trying to clear some of the backlog to do with lesions and rashes. Obviously, with skin cancer, the 2-week rule pathways where you are seen within 2 weeks have always been there. But if you have a patient with a peculiar lesion, even though you might not think it's skin cancer, if you know that there's a 3, 4, 5, 6 month wait to be seen in secondary care, it's usually just easier to get a 2-week rule opinion, and you've excluded skin cancer, you've kept the patient safe, and you've got a rapid turnaround. And this system I'm in charge of is very useful, because although we have had some systems like it before, sometimes the photo is going down to London or to somewhere else in the country for that opinion, whereas the system that I've been involved with in Cheshire and Mersey, it's going to be the local dermatologists looking at their local patients, which I think is a huge improvement.
Totally. Right then, moving on to dermatology below the waistline, what we're going to do, Stephanie suggested that we work from a PDF that she has recommended, and I can't remember for the life of me if we put it up on the website. If it's not up there, we will do, which is from the Royal College of Obstetricians and Gynecologists, which talks about skin conditions of the vulva. And it's a really, I was going to say nice, which is probably not the right word, really not easy to understand, something
Yes.
that basic that we can all understand and relate to, about all the issues that we get as ladies at some point in our lives. So we're starting from this. Maybe it would be an idea to explain the area we're talking about, Stephanie, if you think that's the right place to start, moving through to what can happen, and obviously prevention. And then if prevention doesn't work, how do we then go on to treat some of the symptoms we might have?
Okay, so if we look at this leaflet, I could share the leaflet if that would be helpful.
I think if we just chat through it.
No, okay.
Fine.
So I think the most important thing that I would really like to impress on all the people listening is that your doctor, your practice nurse, your advanced nurse practitioner, we are very, very, very used to looking at vulvas. It is not so much that my life is a constant procession of vulvas, although sometimes it feels like it is, but literally when you come to see us, women are frequently, they are embarrassed, they are miserable, they do not want to be examined, they feel that they just don't want to let us look, and you need to let us look. There is no need to apologize to us. It's just absolutely another part of the body, and people regularly apologize for not being waxed, for having any pubic hair at all, for not being as groomed as they should be, and it's all from my perspective, it's absolutely purely irrelevant. When you come to see me as a doctor, all I want to do is have a look at what's bothering you and make you well. And I really do not mind whether you're wearing knickers or no knickers, or holy knickers, or you haven't been for your normal wax. Or I did once have a lady pick up her teenage daughter's hair glitter instead of some, I think she was basically trying to use some deodorant on the area in case I was offended by a smell. And when she took off her knickers, she'd covered her pubic hair in pink glitter, and that was extremely attractive, if not somewhat startling. That made our consultation go with a bang. But you need to be prepared to show us, because we always need to look. If you are miserable, if you are itchy, if you are sore, please be prepared for the fact that we're going to want to look. And to us, it's just another part of you, and there is no need to feel any embarrassment.
So what are the main reasons that people come? Have they identified what the issue is, or they just say, this doesn't feel right?
Yes, sometimes it's discharge. Sometimes it's frequently it's itch. It's itch and lying awake in bed at night and being unable to stop itching or scratching. Sometimes it's a burning sensation. Sometimes it's outright pain, particularly with what we call dyspareunia, which is pain on sexual intercourse. Sometimes it's skin splitting. Sometimes it's being unable to have sexual intercourse because of the pain. And these days, frequently, I see women who've tried all sorts of odd things and self-help groups off the internet, rather than coming to see their doctor. And they're literally at their wits' end by the time they come in to see me. But I would say itch and burning and scratching are the main reasons. Oh, and sometimes lumps and moles.
Right. Okay. So once you've seen some, I mean, is it a good idea to go through because we've obviously got a list of what the main ones are here. Is it worth whizzing through the list, do you think, or?
I think really what I will be guided by you, be guided by the fact if anybody has any particular questions. I'm quite happy to talk about self-care, which I think is very important, and how you can look after the skin around the vulva best. If anybody has any particular medical problems, I will happily talk about them.
Well, should we start off with generally self-care, and then I can go through the individual ones, and you can explain what you see when people present, and then how you would normally offer help.
Okay. All right then. So really the most important self-care I can think of about the vulva is be gentle. The vulval skin, by and large, which is the area around the opening of the vagina, around the sort of inner and the outer vaginal lips. It doesn't include inside the vagina, but that whole area of skin is simultaneously really rather delicate and yet really very tough. If you think about the whole process of childbirth, that tells you just how much give that skin has. And yet it is an area of skin that we frequently do terrible things to, with harsh soap, with deodorants, with pink glitter, with perfume. And particularly when you're coming to see me around itch, that the number of ladies who have been using perfumed tampons, perfumed sanitary liners, these new vaginal health deodorants and perfumed washes, all these things really are unnatural and very, very, very drying to the skin anywhere, never mind vaginal skin. Your skin wants to be acid. For anybody remembering, like me, who did O-level chemistry and can remember the pH scale, a pH of sort of 0 to 1 is very acid, and 13 to 14 is very alkali, and number 7 is in the middle. Now, your skin wants to be ever so slightly acid. It likes a pH of 5.5, and this applies to the skin all over you. And soap is an alkali. It's a lye, and it wants to drag the pH up to the more alkaline end of the scale. And fundamentally, soap should never really be used for washing the vulval area. You are much safer using any sort of emollient cream to wash with. It won't bubble, but it will look after the skin in a much kinder manner, and it won't dry it out, and much less chance of having perfume in and causing an itch. So that would really be my first piece of advice. Well, my second piece of advice: avoiding anything perfumed, avoiding washing with soap. I have a particular, the number of ladies who seem to think that tea tree oil is a very sensible thing to apply. And along one of my all-time memories, apart from the lady with the pink glitter, was a woman who had recurrent thrush, and she treated herself by inserting a tampon soaked in tea tree oil, and she gave herself internal burns that took quite a while to sort. And we're back to this theme of being gentle and thinking about what you apply. I also reserve a special place of worry about hot tubs. Hot tubs are very, very hot, and obviously we don't call them lukewarm tubs or tepid tubs, and they are seas of other people's shed skin cells, and hot tubs are hardly ever kind to our vulval surfaces. And if you've got any sort of a consistent complaint around vulval soreness or itch, hot tubs, especially the hot tub down the gym that everybody gets in, hot tubs are not a sensible idea.
Yes, I always feel that they're a bit germy.
They are very, very germy.
And I think that about washing is really interesting because, you know, we very much think about, first of all, what we might put on our face. We lots of people wouldn't dream of putting soap on their skin, on their face, because they think they know it dries it out. The next thing you'd probably think about is your body. So if you do suffer from stuff, you would think, well, I'll put an emollient wash on. But somehow, or maybe it's just me, cleaning your other parts is something that it's just something that you do with whatever is available. And it's not something that you necessarily. What about the washes? Because, you know, I know that there's a lot of washes for areas down there. Do you agree with those?
I'm not usually a fan of any of them. I'm not a fan of Dove, even though it's 1/4 moisturizing cream, because it's actually quite perfumed. The smell of Dove is quite distinctive. And most of the other washes, with Femme Fresh is the one that comes to mind. They're not necessary. They're just not necessary. Your vulval area, really. I went to a lecture many years ago where someone described the vagina and the vulva as largely being like a self-cleaning oven. Now that is a very bizarre analogy, and yet the vulval skin and the introitus, the area at the bottom of the vagina, it will look after itself. And really, you shouldn't be introducing anything perfumed or irritant. I also a special word here for sort of lanocaine, which is a proprietary cream available at the chemist, and it says it's for the gentle treatment of feminine itch, or some such words along those guidelines. And all lanocaine is a general anesthetic. So, well, it's not a general anesthetic, it's a local anesthetic. If it was a general anesthetic, you'd be asleep. But it's a local anesthetic cream. And so it isn't really for the treatment of feminine itch, it's for the hiding of it.
It's just numbing it, isn't it?
Yes. Usually, if a lady's vulval area begins to itch, there is a reason for that. And whether it's thrush, whether it's the side effect of some medication that we give for diabetes, whether it's other problems to do, whether it's a vulval eczema, a fungal infection, some other conditions like vulval lichen planus, lichen sclerosus, all those things need looking at and investigating, and sometimes a biopsy and treatment from your doctor. And putting an anesthetic on to numb the itch won't actually be helpful, and could in many ways delay you getting appropriate treatment. So if any of our listeners here today are using copious amounts of lanocaine and hiding their symptoms without showing them to a GP or another primary healthcare clinician, please put the lanocaine in the bin, go and show your doctor or nurse.
So we talked about, how to look after that area. So the washing of it. And I think, what other tips would you say?
Well, there's all sorts of other tips. My most favorite one is avoiding colored toilet paper, which was certainly one that I'd never thought of. But avoid colored toilet paper because frequently there's dyes in it, so which can be irritant. So white toilet paper is the way forward. You need to be avoiding anything synthetic. You need to be trying to wear cotton underwear. And in general, letting a little bit of air get to the area. Synthetic materials can make the skin down there really very sweaty, and with sweaty can come soreness, and all those things should be looked at. Loose fitting clothing is much better for you than tight jeans, obviously. Sometimes it can be helpful with regard to eczema. Whenever I see people with eczema, and this is children's eczema, vulval eczema, anything eczematous and dermatitis-y, it is sometimes a good idea to change your washing powder. because the more super duper your washing powder is, and the newer gets all the stains out, they're usually loaded with biological enzymes designed to break down stains, but they're basically designed to break down protein, and your skin is protein. And very, very sensitive skin will react very badly to these strong washing powders that get stains out. And it's usually better to switch to something like Fairy Non-Bio, which doesn't have the enzyme additives. And the same goes for highly scented fabric conditioners. You need to be avoiding those too.
So the old bloomers were a good thing that they used to wear in the olden days because it let air in.
Bloomers were great. Bloomers were great. Bloomers let the air circulate. And that's normally a very good thing. The other thing that you can do if you find, and I sometimes see ladies who complain about scratching all night, and I had one lady not long ago who was actually able, the itch was so bad, the only way she could help herself was to twist the vulval skin. And she showed me, and it was actually quite eye-watering, but it was a very effective way of getting rid of the itch, largely I think because she distracted herself with the pain. But if you are a constant scratcher, cut your nails. Because cutting your nails short is always very helpful. Cut your nails and avoid perfume and avoid known allergens.
I saw something recently, and it was about, and I can't remember what it was on. It was about a survey as to whether you wear underwear at night times or not. Does it matter if you wear underwear at night time?
My advice would be not to, because again, we're back to letting the air circulate. And really, if you cannot bring yourself to sleep naked, then if you're wearing a night dress, then I wouldn't particularly wear underwear with it. No, better to let the area self-regulate a bit.
And actually, that sort of takes me on to a question about, we do a lot around bladder and bowel issues, and so for people that have to wear, they have to wear very thick pads, for example, in their knickers, especially at night times when the flow can be much stronger. Is there anything that you would suggest, like putting some barrier cream up there before? Or
that may well be helpful. Obviously, with the use of the thick pads, you can end up with a nappy rash because urine is quite irritant, and feces have got bile acids in, which are also quite irritant, and you are back to having a cool bath or a shower before bedtime. Something that we didn't look at before was the temperature of the water that you are washing in. And it doesn't matter to me whether it's a bath or a shower, except clearly if it's a bath, you will not be putting, I don't want Radox in, I don't want anything perfumed, I don't want bath salts. The important thing is the temperature. And my routine question to patients when I say to them, how hot is your bath or shower water? And actually, really hot water is a really, really good way of dealing with itch, because it will temporarily distract all the nerve endings, and the itch itself will shut down for a while, and you will gain some measure of relief. Unfortunately, really, really, really hot water is actually quite damaging to the skin, and it can worsen an eczema. It will dry out the skin even further. And my stock question, particularly when patients look shifty when they tell me that they bathe in or shower in cool, tepid water, is when you are in the shower, could I hand a baby to you?
Yeah.
And if they look at me quite confidently and say, oh, yes, then I know that their bath shower water is at the right temperature. If they immediately say, oh, no, it will be far too hot, it's too hot. If it's too hot for the baby, then it's too hot for somebody who's experiencing, vulval dermatological symptoms, and you need to turn the temperature down. So you would be looking at some sort of, cool shower before bedtime because frequently the people that we are talking about have those sorts of issues in the day too. And it's important, I think, to make sure that the area is clean and dry before bedtime. And sometimes applying a little bit of light barrier cream can help. I still have a lot of patients that use Sudocrem for that sort of thing, but there are other ones on the market like Conatrain, which rather than using zinc and zinc oxide, and that's what gives zinc and titanium, or what give Sudocrem and Metanium those sorts of very traditional barrier creams. That's what give them their waterproof, moisture resisting, skin protecting components. Some of the newer ones like Conatrain, and there's another one, Aproderm barrier, they've got a bit of silicone in, and so they're sort of a little bit less gloopy, but very, very skin protective.
I was interested when you said about hot water, how it sort of takes away because it changes the senses. Likewise, could that be said if you did it with very cold water?
Unfortunately not.
Oh.
No. Then you'll just get goose pimples and be very miserable. So no.
That doesn't work. Okay. Right. So cleanliness, making sure, put a barrier cream on if you do, a light barrier cream, the right barrier cream. No Radox in baths and things like that. No perfume, none of the nice things.
No, ideally, no bubbles.
No bubbles, okay.
No bubbles. I usually tell all of my patients with vulval issues, they need to wash with emollient. The ones that we particularly are fond of, I quite often give Dermol. Dermol is a very nice lotion, is a very nice light emollient that we use as a soap substitute. We sometimes use another one called Aproderm Oat, and all these can be bought or prescribed. But it is odd to me that the vulval washing and light emollient of choice is always something called Cetraben. And I must admit, I don't know why, because there are lots of emollients out there, and when you are using them to wash with, it really doesn't matter which one you use. They are all equal. But I did my vulval dermatology training in Chester, and around here I've got experience of what they do in Liverpool and in Manchester, and we all seem to use Cetraben. It's our go-to vulval emollient and washing solution. And the other month, I listened to a person like me, a GPSI with a person with a special interest in dermatology, and she was also talking about women's health issues. And most of us, there's a relatively small circuit of us who talk, and we all know each other, and we all sometimes just log in to each other's talks just to see what the competition is saying. And I thought, oh, well, this would be very interesting. I shall see how they do things in London. And one of the things that I particularly remember from her talk was she also used Cetraben as her go-to vulval emollient and washing solution. And I genuinely don't know why. It's our de facto choice.
Yeah, well, they've been one of our customers, and we've definitely been promoting them or have promoted them before. So, okay.
The other thing that you need to do, I should mention here, is not only are you washing with it and moisturizing with it, but if you have any sort of vulval skin issue, every time you go for a wee and you've wiped yourself clean, pop a little bit of moisturizer on afterwards, because that will also help soothe the skin. Then wash your hands.
Actually, that's made me think about, because you also can buy those tissues, can't you? Those
no,
that's a no. I think they're environmentally very bad.
Don't care. No, they're bad. No, I don't want any intimate feminine cleansing wipes, or just no.
Fine, right, we'll swiftly move on there. I didn't mention that, but as I said, I think they're a big environmental problem, aren't they?
Yeah.
So, okay, so going on through to looking at some of the more common conditions that you will see, the first one being lichen sclerosis.
Lichen sclerosis is, I think I would put them in a slightly different order than they are on the leaflet. And
Okay.
if we're talking about common, our common one is vulval eczema, which is also sometimes called vulval dermatitis, and that can lead to a thing called lichen simplex.
Okay.
Vulval dermatitis, vulval eczema, is frequently caused by overwashing, and overwashing using harsh chemicals, too much time in the hot tub, and the consistent application of perfumed products in our self-cleaning oven area. And the problem is, once you have itched and scratched, your body begins to protect itself, and it will lay down what we call lichenification. And that's basically where the skin becomes massively thickened, and the skin gets quite a sort of crinkled and creased appearance because it's been scratched. And my standard eczema rule is like, children, particularly when their eczema is itchy, they will scratch. And anybody here with young children, they will all know that children scratch they scratch the insides of their elbows here, and they scratch behind their knees. And it's very common for me to see lichenification in children behind elbows and knees, and that means that they've scratched about 10,000 times by the time I've seen that level of skin thickening. And it is not uncommon for me to see lichen simplex with a good ongoing vulval eczema, and it just means that you've scratched and scratched so much that you thicken the skin. And the most this is such a common problem, and what we need to do really is, number one, stop making it worse. And that's all the things that we've talked about so far around turning the bathwater down and cotton underpants and no colored toilet paper. Yeah. But we need to break that itch, scratch, itch cycle and stop them scratching so that the skin can get that back to normal. Sometimes this needs a little bit of topical steroid to soothe down any itch and inflammation. And that normally works very well. Unusually, and sometimes you can get, you can buy them. Sometimes they go out on prescription, not very often. Most NHS guidance says that your GP shouldn't prescribe them. But there are several companies on the market who make silk underwear. Now, do not be thinking that these are exotic garments of bedroom allure. NHS silk underwear is not an exotic garment of bedroom allure. It's a very close knitted, quite thick sort of jersey silk fabric, which has been shown to have an antimicrobial action. I think in some cases it's also quite cooling, and it's very good both at stopping the itch sensation, sometimes by a little bit of pressure because it's cooling, but also it protects the skin. And if you are a midnight scratcher, having spent 5 minutes talking before about the importance of sleeping without underwear at night, if it's a really severe problem and you can't stop scratching, the silk underwear, and the one I know most commonly, there's quite a few on the market. There's skinnies. The one I tend to use or recommend my patients buy is called Dermasilk. And the reason I tend to stick with them is pure, or I advise them is purely because when these garments were launched, maybe, I don't know, 10, 12, 15 years ago, I have a son with eczema. And at the time, they were giving out samples for doctors to try or to give to patients to try before they bought them. And I got sizes. I got sizes for my son from all the companies, and I literally took them all home and I made him wear them in bed at night to stop scratching. And then I put them in my washing machine on delicate, and I washed them all to see what they turned out like, how they kept their shape, whether it was a little controlled trial of one. And the Dermasilk range consistently performed best. He liked them best. They felt nicest. They didn't fall apart with washing. So I tend to recommend Dermasilk. And if you go on the Dermasilk website, you will find their silk underwear.
I have to say, this is not a paid advertisement.
No. Dr. Gallard is giving you the benefits of all the things that she's tried. And I would add, please do not go to your GP and ask him to prescribe them, because they're not NHS prescribable. They are not.
Okay.
But
So, okay, moving on then from vulvar dermatitis or eczema, the next one would be...
The next most common one that I see is often genitourinary symptoms of the menopause. And that's where you have gone through the menopause and the skin around the vulva becomes very dry, very tight, very sore. The skin can split. And a lot of women think that these are just the normal changes of the menopause. And some women sail through the menopause, some women choose to go on HRT and not have a menopause, and some women just think that it's all normal. And those sorts of things, again, it is always worth consulting your GP for. Frequently, with the menopause, it's the estrogen is what keeps all the vulval skin sort of, plump and moist and not dry and healthy. And when you go through the menopause and that estrogen is withdrawn, that's when a lot of the problems start. And because of the way the estrogen functions, you can also start losing that estrogen sort of plumptiousness around the neck of the bladder. And that's when you start to see a little bit of incontinence happening. Oh. And when you add up dry, sore, tight skin and a little bit of leakage of wee, that's when you can end up with some really, really nasty, irritant dermatitises made worse by urine leakage.
Wow.
And I see that very commonly. And it almost looks, I think of one lady from about 10 years ago, and when we had a look, and I think she required about 3 visits before I could persuade her to let me have a look, because she was a lady in her 70s. And when she took off her underwear and we looked, it was almost like a chemical burn. Whoa. It was awful. And she'd been like that for about 10 years.
Oh my goodness.
And we swapped her coal tar soap for some emollient of whatever, probably Cetraben, but whatever. And we gave her a course of internal HRT, the topical estrogen, which you instill with an applicator, much like a Tampax applicator. And that's a little pessary. And you use that once, you insert a pessary once every night for 2 nights, and then twice a week ad infinitum. And it puts a very low dose of estrogen in the system. Most of the estrogen is absorbed in the vulva and around the in the vagina and around the neck of the bladder, and it will return the skin to approaching normal. Often it will settle with the urine leakage, and the skin will heal once you've stopped washing with soap and you're just applying moisturizer.
Gosh, well, I'm very pleased she went to see you and you persuaded her to show, because the thought of that is horrendous. And I'm sure lots of people live like that because you don't understand what's necessarily happening to your body.
Or that it's not normal. And I think at the time she said, oh, well, my mother was like it. And I said, well, never mind. We've moved on since then. And sometimes ladies of that age require a little bit of support to start using internal estrogen with the applicator. But the benefits are just huge. Absolutely huge. And that sort of vulval soreness secondary to the menopause is very common.
Gosh, okay. Then I would have thought thrush must be coming up next.
Thrush, yes. Thrush is often self-diagnosed because it seems to be hardwired both into our feminine thinking, but also the medical thinking that the first thing you've got to exclude with an itchy vulva is thrush. And it just isn't always the case. Sometimes it's, you know, there's lots of other things, and frequently I see women with itchy vulvas who've normally got a long history of self-treating for thrush, treating themselves with the over-the-counter pessaries, the over-the-counter creams, the over-the-counter capsules that you can buy. I think it's made matters worse, really, that the over-the-counter capsules and creams are now available on things like Groupon. Oh, wow. And they are ridiculously cheap if you go looking for sort of thrush treatments on Groupon. And the relief that these women get is at best transient, and they normally need to come in and have some swabs and let somebody have a look, because if you genuinely are having recurrent thrush, you may well need to go to your nearest sexual health clinic, because they are the experts in this sort of thing, and there's usually a regime of medication that they can put you on. I was informed by one of them at a BASH conference, the British Association of Sexual Health and HIV, that they viewed with chronic thrush success was when a patient was on anti-thrush medication for less than 6 months of the year.
Wow.
There's also some other things that they will do that aren't commonly available, such as if you go to see your GP and we swab you, the yeast that most commonly causes thrush is called Candida albicans, and we're all very, very aware of it. But there is another strand, there's another type called Candida glabrata, and that will not respond well. It will not respond well to clotrimazole, and it will not respond particularly well to fluconazole. Sometimes different treatment is needed, but you will only pick that up off a swab if your GP has asked for what we call speciation. And your GP would need to ask to do that. Now, sexual health clinics will do that without thinking, because sexual health and looking after chronic thrush is a sexual health clinic's bread and butter in a way that it isn't for general practice. So if you're suffering with any sort of chronic thrush, a gynecology referral or a sexual health clinic is very much the place to go.
Right. So I'm very aware that time has just whizzed on, and we actually only have 10 minutes left. So we've got a number of questions have come in. So I'm just wondering, is there anything else that you want to say before we move on to questions? Because I'm very keen to answer the questions.
Recurrent soreness, recurrent itch, any peculiar fast-growing little lump, little ulcer, little patch of whiteness. There's a condition called lichen sclerosus, which again is very, very, very commonly seen in general practice and occasionally just not always diagnosed. Anything like that, particularly the fast-growing lumps and bumps, your GP will always want to see them. I would also very quickly add, lichen sclerosus is one of the few conditions that we treat with a potent long-term maintenance steroid.
Right.
And we use that steroid. Most GPs get we are very wary about prescribing long-term potent steroids. And this is largely a hangover because of things that happened in the sort of 70s and 80s, and long-term potent steroids must be looked after. But as far as I know, our thinking, and if you remember, one of the first things I said was that your vulval skin is simultaneously quite delicate and as tough as old boots. And a long-term potent steroid such as Dermavate used on the vulva for lichen sclerosus is absolutely fine. And usually I give it out either twice a week for maintenance with instruction to step it up for flares, or I will just give them a 30-gram tube and say, do with this as you will, but as long as you're using a 30-gram tube or less for 6 months, then that's fine, and your level of use is acceptable.
Well, you have just answered one of the questions that we had sent in to us.
Okay.
By a lady who said she's 70 years old, and she's always been using what you've just said, but the doctor said you can't keep using it, but you're saying absolutely this is fine.
It is my common working practice, and the common working practice of every vulval and sexual health doctor I know when we're dealing with lichen sclerosus. Twice a week maintenance use is absolutely fine. Right. Because these ladies are taught very well by the clinics to only use a tiny pea-sized amount. They are not, applying it with a shovel. And less 130-gram tube in less than 6 months is absolutely fine. You're just not going to see long-term problems. Yeah.
Okay. Shall I move on to the questions now that we've sort of gone in?
By all means.
Yeah. I've got a feeling that I know the answer to this one. I have a rash of tagwarts which are now spreading, and wart removers don't work. What should I do?
Sexual health clinic.
Yeah,
absolutely. Sexual health clinic. They may well be skin tags. They could also be little vulval warts. In either case, a sexual health clinic is the place rather than dermatology.
Okay. Right. About a half-inch black skin near outside of genitals, possible mole. Spoke to GP. Wondered, what do you think?
Okay. Relatively hard to give a diagnosis without a photo. Please do not send a photo. I don't think the airwaves are ready for that. Seborrheic warts are very, very common on our genital and vulval area. A seborrheic wart is a pigmented sort of an overgrowth of grease glands, particularly common over the age of 40. Might be one of those. Might also be what we call an angiokeratoma, and that's a little hard knot of blood vessel, frequently quite dark in color, and people think they are moles. It could also be, depending on the general constitution of skin, it could even be a blackhead, a comedone. They're not uncommon down there. I cannot diagnose without a photo. I do not think this is the appropriate forum to give me a photo, but I would say ask your GP, and if your GP has any doubts, they'll send you off to a clinic.
Yeah. Okay. I was diagnosed with LS last year, which eventually biopsied and was keratosis. No scans, just white skin. A different gynae said just thickened skin. What can I use, please?
Well, thickened skin is normally secondary to excessive scratching. Keratosis is thickened skin, so it's not. You would need to sort of think about your regime, and it's all the things that we've talked about. It's avoiding heat, it's avoiding perfume, it's avoiding any sort of skin irritant, and using lots and lots and lots of moisturizer, and breaking that scratch itch cycle.
Yeah. You've not suggested a peri bottle to remove urine before using creams.
No, I haven't. I've never. A peri bottle?
I don't know. I don't know what that means, unfortunately.
No. Well. Unknown person, maybe I should, but in all my years of dermatology and doing vulval dermatology, that's never been suggested. Okay.
What would you recommend for the treatment for LS if you also suffer with genital herpes and steroids are an issue, please?
Difficult, because of course steroids are immunosuppressants, and what we don't particularly want is for the use of the topical steroid to make it easier for an outbreak of genital warts to occur. If the genital warts are particularly troublesome and flaring quite commonly, then I would suggest going on the prophylactic medication. Usually we give acyclovir to prevent the warts coming out. But that's quite difficult to manage. The other thing you could try is the use of a topical immunomodulator, but in all which we sometimes use the steroid sparing, but you could possibly be even worse off using a topical immunomodulator. It would depend how often, I think, and how frequently you were getting a flare-up of the genital warts. Maybe twice weekly steroid would not be enough to lower your immunity to the point where you were more likely to get a flare-up. But if it was a consistent, persistent problem, I would be contemplating whether I might need acyclovir prophylaxis of the warts to enable me to apply the steroid cream in safety.
Okay. Oh, somebody's very kindly come up. Very common for patients to use a peri bottle after urinating with diagnosis of LS. It's just a spray water bottle, very useful for those with fissures that sting passing urine. Well known in internet forums, not so well known to GPs.
Definitely not well known to GPs.
However, it says a godsend for many. So
I'd be thinking, why don't we heal the fissures? Never mind spraying water on them. Why don't we heal the skin fissures with decent steroid? I, as a GP, would view fissures as failure, and normally I can get quite good results with healing skin fissures with my, cutting out irritants, adding moisturizers and topical steroids. But obviously I agree, I've got an interest in these things, and I'm willing to see patients again and again until I've made it right.
Well, that's the end, because we've neatly come to almost 1 o'clock. So thank you so much. What I'm going to do, well, first of all, there was a lot of really good advice. So the webinar will go up live very quickly for people to recap, and I'm sure the people who've asked questions will be interested to go through what you've said, because you gave so much detailed information and medication and all the long words that I'm useless at remembering. So it's always good to recap. And we'll put the PDF up as well if it's not already there. And make sure that everybody has access to it. Yeah. So that
I would add, thinking about the leaflet, to be fair, is not, it was, I think it's 2013 if memory serves,
it's an old
and
one.
They haven't updated it, but the information remains current. The advice in it remains very sensible.
Yeah, I mean, it's sensible stuff that we all know, but I suppose when you're looking for a miracle cure and you don't want to go and see the doctor for various reasons, it's important to look at these things, isn't it? And not to go to get something that's perfumed.
Yes, absolutely.
And not to spray perfume down there.
Indeed pink hair glitter. No, pink hair glitter right out, unless you want to lift the spirit of afternoon surgery.
Thank you so much, Dr. Gallard, for your time. It's just been really, really helpful, I'm sure, for so many people. And all those, and I think for me, the thing that you've really pushed home is that you see this all the time. You may not have seen mine, but which is what I think one always feels, well, you haven't seen mine, but I've seen everybody else's. And
I have.
Not to be embarrassed, to get on with it and sort out the problem before you might make the problem worse.
Absolutely.
Yeah.
And my final, don't forget, any fast growing lump or lesion or ulcer or soreness, anything that wasn't there last month, is there this month and isn't healing, go to your doctor. We really want to see that.
Yeah, absolutely. Thank you so much. And thank you everyone for tuning in. Thanks. Bye.